Hello everyone, it's Dr. Locklear here, and we're still continuing the concept of inflammation, and we're looking at Exemplar 10E, which is peptic ulcer disease. So you probably, just from the stress of nursing school, may be feeling some GI issues, and stress is a factor that can lead to peptic ulcer disease because it causes more secretions in the stomach, that acid, and it just eats away at the stomach. So you probably all are feeling that right now. So let's get started and look at this. It's your gut instincts that are causing your ulcers. And I just had to laugh. But when you think about it, and it's like what I just said, it's the stress does play a role in putting more pressure on our body, and our stomach is not exempt from that. So a lot of times when we're feeling a lot of stress, we eat differently, and we eat foods that are not good for us and things that can cause peptic ulcer disease. We don't sleep good. That can cause it as well. And so let's look at our patho and see what happens with peptic ulcer disease. The term peptic ulcer disease describes a condition in which there is discontinuity in the entire thickness of the gastric or duodenal mucosa. And so this mucosa, our stomach, that's their stomach lining, and our stomach lining is pretty thick. And it has to be because our stomach is constantly producing this acid and pepsin and gastric juices to, of course, break down the food that we eat so it can pass on, through the gut and into the small intestines and be absorbed properly. So our lining has to be very thick. So to get an ulcer, you've had a lot of irritation to that gastric lining. Our learning outcomes, we're going to look at the pathophysiology of peptic ulcer disease. How does it occur? What causes it? What are the risk factors? The clinical manifestations, what will you see? If you look on page 757 of your book, you will see a picture of a peptic ulcer, and this one's what they call superficial. So if it's not treated, it's just going to get worse. How is it diagnosed, and how do we collaborate care? How do we treat it, and how do we treat across the lifespan? How do we treat children versus adults? And how do we apply the nursing process? What do we assess, and what are our interventions to help someone live with peptic ulcer disease or resolve it altogether? So what is our overview? And as you can see in the picture here, you can see where the lining of the mucosa has been eaten away, and you've got these little open wound areas and sores, and they're very irritating. You can see this one, it's got irritation around it, and they can bleed. So sometimes you'll cough up blood and you'll have a lot of epigastric pain. So in our overview, peptic ulcer disease is a chronic health problem caused by a break in the mucus lining of the GI tract where it comes in contact with gastric juices. Peptic ulcers may occur in any area of the GI tract exposed to acid, pepsin secretions. And look at that word, acid. We know acid breaks down things, so it's going to break down the food we eat, but the more acid we have, it affects that lining. It includes the esophagus, the stomach, and the duodenum. The most common are duodenal ulcers, which usually develop between the ages of 30 and 55 and are more common in men than women. Gastric ulcers, which occur in the stomach, more often affect older patients between the ages of 55 and 70. Ulcers are more common in individuals who smoke, because we know smoke, the nicotine and the smoke itself can be very irritating to the esophagus and to the lining of the stomach. Also, this irritation to the esophagus can lead to cancer. These peptic ulcers can turn into cancer in the stomach as well. Alcohol, we know alcohol has a burning sensation as it is consumed, and so it kind of eats away at the lining as well. Alcohol and dietary intake do not seem to cause peptic ulcer disease, and the role of stress is uncertain. So here in your text, it just kind of bases their evidence on that alcohol and dietary are maybe not concerns, and that stress may not be a concern, but in other things that I have read and over the years, in my years as a nurse, these can be uh, issues as well. So let's look and see what our text says about it. So in the patho, the innermost lining or layer of the stomach wall, the gastric mucosa, consists of columnar epithelial cells supported by a middle layer of blood vessels and glands and a thin outer layer of smooth muscle. So your stomach's like a muscle. The mucosal barrier of the stomach, a thin coating of mucus gel and bicarbonate, protects the gastric mucosa. The mucosa barrier is maintained by bicarbonate secreted by the epithelial cells, by mucus gel production stimulated by the prostaglandins, and by an adequate blood supply to the mucosa. An ulcer develops when the mucosal barrier is unable to protect the mucosa from damage by the hydrochloric acid and pepsin and the gastric digestive juices. Helicobacter pylori, or H. pylori, infection is found in about 70% of individuals who have PUD, is unique in colonizing the stomach. It is spread individual to individual, oral to oral, or fecal oral, and contributes to ulcer formation in several ways. The bacteria produce enzymes that reduce the efficacy of mucus gel in protecting the gastric mucosa. The host inflammatory response to H. pylori contributes to gastric epithelial cell damage without producing immunity to infection. So in other words, H. pylori is a big factor to peptic ulcer disease as well. A big factor, I mean, look at the numbers here, 70%. Although the gastric mucosa is the usual site for H. pylori infection, this infection also contributes to duodenal ulcers. The reason may be increased production of gastric acid associated with H. pylori infection. And so I want to go back to where it said alcohol and dietary intake do not seem to cause pelvic ulcer disease, but alcohol and dietary intake can be a factor in gastric cancer and esophageal cancer, which can cause irritation in the stomach. So these are things that still need to be avoided because it is very irritating to the esophagus and the stomach as well. I don't want you to take that lightly, that it's not an issue, but it's more of an issue in causing cancer and those type of situations. NSAIDs contribute to peptic ulcer disease through both systemic and topical mechanisms of injury. Prostaglandins are necessary for maintaining the gastric mucosal barrier. NSAIDs interrupt prostaglandin synthesis by disrupting the action of the two COX enzymes. COX-1 is necessary to maintain the integrity of the gastric mucosa, and COX-2 responds to inflammatory stimulation. The COX-2 selective NSAIDs may be less damaging to the gastric mucosa because they have less effects on the COX-1 enzyme. In addition to their systemic effect, aspirin and many other NSAIDs exert topical injury by crossing the lipid membranes of gastric epithelial cells, damaging the cells themselves. So, peptic ulcer disease is definitely a direct effect from NSAIDs and aspirins and things of that nature. The ulcers of PUD may affect the esophagus, stomach, or duodenum. They may be superficial or deep, affecting all layers of the mucosa. Duodenal ulcers, the most common, usually develop in the proximal portion of the duodenum close to the pylorus. They are sharply demarcated demarcated and usually less than 1 centimeter in diameter. And you've got a picture on page 757 down at the bottom, and it shows those little ulcers in the lining of the stomach. Gastric ulcers are often found on the lesser curvature and the area immediately proximal to the pylorus. Gastric ulcers are associated with an increased incidence of gastric cancer, and that's what I was saying. You know, don't think that alcohol and dietary certain foods they do affect the issues of the stomach. So maybe not directly, peptic ulcer disease. Peptic ulcer disease may be chronic with spontaneous remissions and exacerbations. Exacerbations of the disease may be associated with trauma, infection, or other physical or psychological stressors. And again, here they're talking about those psychological stressors, but your text and whatever evidence base they use was saying that stress may be an uncertain factor, but there are documented studies that show that the more stressed you are, the more gastric juice that you produce. So what is our etiology? H. pylori infections often occur in childhood and can spread via unclean water and through saliva. Actual timing of infection is unknown for almost all patients. So what are the risk factors? Chronic H. pylori infection and chronic use of NSAIDs, including aspirin, and here's the key, are the major risk factors for peptic ulcer disease. Overall, an estimated 1 in 6 patients infected with H. pylori develops PUD. Of the NSAIDs, aspirin is the most common drug that causes the ulcers, ulcerogenic. Cigarette smoking is a significant risk factor, doubling the risk. Cigarette smoking inhibits the secretion of bicarbonate by the pancreas and may cause more rapid transit of gastric acid into the duodenum. Other risk factors include low socioeconomic status, because, if you don't have the money to go to the doctor, you don't get it treated and it just gets worse. Crowded, unsanitary living conditions, which lead to unclean food and water. Advanced age, history of ulcers in the family, and concurrent use of other drugs such as glucocorticoids and biphosphonates. So it's not just NSAIDs and aspirins, but you've got to look at some of these other drugs as well. Prevention. The etiology of peptic ulcer determines what actions are possible to minimize the risk of developing the disease. Given that H. pylori is so common, prevention of infection does include good hand hygiene, because remember it was talking about the oral route, drinking clean water, and correctly preparing food. However, since most infections are thought to occur in childhood and infection is asymptomatic for most people, avoidance is difficult because you don't have the symptoms. For patients whose history includes long-term NSAID use, recommendations include adding either a histamine receptor antagonist, a PPI, which is a proton pump inhibitor, such as Protonix, or the drug Cytotec, which is very good for the stomach, or changing treatment to a COX-2 selective NSAID, which reduces the occurrence of peptic ulcers. All patients started on long-term therapy when non-selective NSAIDs should be tested for H. pylori regardless of their level of risk. And so this H. pylori is a big factor. It is a infection that is found in food and water, and guess what? We eat food and water, so it needs to be cooked properly, and we need clean drinking water. What are the clinical manifestations? Abdominal pain is the classic symptom. The pain is typically described as gnawing, burning, aching, or hunger-like, and is experienced in the epigastric region, sometimes radiating to the back. The pain occurs when the stomach is empty 2 to 3 hours after meals and in the middle of the night, because we know when we're sleeping, we're kind of fasting, and is relieved by eating with a classic pain food relief pattern. The patient may complain of heartburn or regurgitation, which means it comes back up in the throat, and may vomit. It may come all the way back up. The presentation of PUD in the older adult is often less clear, with vague and poorly localized discomfort, perhaps chest pain or dysphagia. So, of course, they're going to rule out cardiac, weight loss, or anemia. In the older adult, a complication of PUD, such as upper GI hemorrhage or perforation of the stomach or duodenum, may be the presenting symptom. And so that's when they seek help, is when they start having those complications. The complications associated with peptic ulcers include hemorrhage, and I got your picture here of one that's hemorrhaging, obstruction, and perforation. So hemorrhage, this is blood in the stool, either obvious or occult. Hematoemesis, so when you throw up. Fatigue, of course, weakness and dizziness if you're losing blood, and those orthostatic blood pressures. And hypovolemic shock, so low volume, you're losing blood. Obstruction, so you'll see nausea and vomiting, sensations of epigastric fullness, electrolyte imbalances, and metabolic alkalosis. Perforation, you'll have severe pain in the upper abdomen radiating to the shoulder, rigid and board-like abdomen, so we need to do a good assessment of the abdomen, absence of bowel sounds, diaphoresis, tachycardia, rapid and shallow respirations, and fever. Among individuals with PUD, 10 to 20% experience hemorrhage as a result of ulceration and erosion into the blood vessels of the gastric mucosa. In the older adult, bleeding is the most frequent complication. When small blood vessels erode, blood loss may be slow and insidious, with occult blood in the stool the only initial sign. If bleeding continues, the patient becomes anemic, experiences symptoms of weakness, fatigue, and dizziness, and those orthostatic blood pressure, because you're losing volume. Erosion into a larger vessel can lead to sudden and severe bleeding with hematoemesis, which is throwing up blood, melena, which is blood in the stool, and hematochezia and signs of hypovolemic shock. Gastric outlet obstruction. This is obstruction of the pyloric region of the stomach and duodenum that impairs the gastric outflow, may result from edema surrounding the ulcer, smooth muscle spasm, or scar tissue. Obstruction is a gradual rather than an acute process. Symptoms include a feeling of epigastric fullness, attenuating ulcer symptoms, and nausea. If the obstruction becomes complete, vomiting occurs, and it can be like projectile vomiting. Hydrochloric acid, sodium, and potassium are lost in the vomitus, so now you're going to have an electrolyte imbalance that leads to metabolic alkalosis. The most lethal complication of PUD is perforation, penetration of the ulcer completely through the mucosal wall. When this perforation occurs, gastric or duodenal contents enter the peritoneum, or your peritoneal cavity in your abdomen, which causes an inflammatory process in peritonitis. Chemical peritonitis from the hydrochloric acid, pepsin, bile, and pancreatic fluid is immediate. Within 6 to 12 hours, bacterial peritonitis follows from gastric contaminants that enters normally the sterile peritoneal cavity. So now you got a major infection going on. When an ulcer perforates, the patient has immediate severe upper abdominal pain radiating through the abdomen and possibly to the shoulder. The abdomen becomes rigid and board-like, and bowel sounds are absent. And then you'll start to see signs of shock, such as diaphoresis, tachycardia, rapid shallow respirations. Classic symptoms of perforation may not be present in an older adult. Instead, the older adult may present with mental confusion, and we talked about that on some other recordings that I did. That anytime you see a patient that has a change in their mental status, you know something's going on, something's causing it. This atypical presentation can lead to delays in diagnoses and treatment because it mimics so many other things. Then you have a condition called Zollinger-Ellison syndrome. This is a form of PUD caused by a gastrinoma or gastrin-secreting tumor. Gastrinomas may be benign, which means they're not malignant, although they are usually malignant. Gastrin is a hormone that stimulates the secretion of pepsin and hydrochloric acid. The increased gastrin levels associated with these tumors result in hypersecretion of gastric acid, which in turn causes mucosal ulceration. The peptic ulcers of Zollinger-Ellison syndrome most often affect the duodenum, but may involve the stomach or the jejunum. Characteristic ulcer-like pain is common. The high levels of hydrochloric acid entering the duodenum overwhelm the protective buffering mechanism. The result is diarrhea and steatorrhea, which is excess fat in the feces, and steatorrhea smells really, really bad and it looks really nasty. This is from impaired fat digestion and absorption. Complications of bleeding and perforation are also seen with this syndrome. Fluid and electrolyte imbalances also may result from persistent diarrhea with resultant losses of potassium and sodium in particular. So this is a very serious condition because you can get dehydrated and get in a fluid imbalance and either be in an acidotic state or in an alkalosis state, which is not good because your body's got to maintain homeostasis. Collaboration. Treatment of PUD focuses on treating its cause. Primary treatments include eradicating H. pylori and treating or preventing ulcers related to the use of NSAIDs. The nurse plays an essential role by providing ongoing assessments and very detailed teaching for these patients. So what are the diagnostic tests? Upper GI series, this is using barium as a contrast medium, can detect 80 to 90% of peptic ulcers via X-ray. Gastroscopy allows visualization of the esophageal, gastric, and duodenal mucosa and direct inspection of the ulcers. Tissue also can be obtained for a biopsy. Biopsy specimens obtained during a gastroscopy can be tested for the presence of H. pylori by several different methods. In the rapid urease test, the specimen is placed on a gel-containing urea. If urease from H. pylori is present, it will convert the urea to ammonia and carbon dioxide, increasing the pH of the gel. This action leads to a color change of the pH indicator in the gel to produce a positive result. Results are obtained within 1 to 24 hours. Biopsy specimens also can be microscopically examined or cultured for H. pylori. Non-invasive methods, they use serologic testing, and they use antibodies through the ELISA test. Fecal antigen immunoassay test, and this detects antigens to H. pylori in the feces, and the urea breath test. In the urea breath test, the radio-labeled urea is given orally. The urease produced by H. pylori bacteria converts the urea to ammonia and radio-labeled carbon dioxide, which can then be measured as the patient exhales. This test, as well as fecal antigen testing, can also be used to evaluate the effectiveness of treatment to eradicate H. pylori because they won't blow out that urea. Treatment with proton pump inhibitors interferes with the urea breath test results, so these drugs should be continued for 14 days. So if you're on a PPI and you've got to have some of these tests, 14 days, 2 weeks. And then gastric analysis is used to determine Zollinger-Ellison syndrome. And look on page 759. It talks about clinical manifestations peptic ulcer disease, and it gives you your H. pylori or NSAIDs, hemorrhage, obstruction, and then perforation. Your clinical manifestations, and I've already gone over these, but they just put it in a nice chart for you, and then they give you the treatments. So for H. pylori, you want a PPI with 2 antibiotics. Discontinue the NSAIDs, and you want to use a H2 receptor agonist and a mucosa protecting agent. And there's a drug out there called Carafate that really protects and coats the the stomach. Bismuth-containing product with 2 antibiotics and the PPI. And so make sure you read over that, okay? Like for the hemorrhage, they may need fluids. They may have to be NPO to calm the stomach down. They may have to have surgery. They may be vomiting. They may need some Zofran, you know, those kinds of things. And then for obstruction, you want to look at electrolyte imbalances, and then perforation, you want to look for those signs of infection. So please read this chart. Surgery, the identification of H. pylori infection as the primary cause of PUD and the availability of drugs to effectively treat and heal peptic ulcers have dramatically decreased surgery as a treatment option. Older patients, however, may have undergone gastric resection and may have long-term complications related to surgery. And I got you some pictures here of the different things that they can do for the gastric resections. I just wanted you to see those pictures. Pharmacological therapy, so what are the drugs that we use? And you see here 2 antibiotics plus a proton pump inhibitor such as Protonix. Discontinue the NSAIDs. And if you have to have something, they will recommend that you take enteric-coated medications because those dissolve in the bowel, not the stomach. Some of the drugs that are used to treat gastroesophageal reflux disease, or GERD, are also used to treat peptic ulcer disease because of the need to treat the erosive effects of hydrochloric acid. GERD is covered in another chapter, but some of the drugs that they use are also the same. These drugs include your H2 receptor agonists, H2 blockers, and proton pump inhibitors. So, for example, your H2 blockers are cimetidine, which is Tagamet. They block histamine, which reduces the secretion of hydrogen ions from the lining of the stomach. Proton pump inhibitors, such as omeprazole, Prilosec, block the secretion of gastric acid by inhibiting the ATPase pump in the stomach. For a complete list of drugs, you can look on medications 4.2 to see those drugs, and that is on page, let me see, it's under the digestion chapter, and 4.2 is on, let's see if I can find it, there's 4.1, and 4.2 is on page 259. And it gives you all kinds of antacids, your H2, Tagamet, Pepcid, Acid, proton pump inhibitors. Protonix is listed there, and that's page 259. So you may want to look there. Peptic ulcer disease, however, has other causes that are treated differently. An infection with H. pylori and an ulcer caused by overuse of NSAIDs. The goal of treatment with these other medications is to eradicate that H. pylori, protect the mucosa, allow the ulcer to heal, and avoid the development of gastric cancer. So again, you may, you know, this can be very serious and lead to other issues. Eradication of H. pylori depends on using drug regimens with proven effectiveness, and this varies depending on the presence of resistant strains of H. pylori in different parts of the country. Multiple drug therapy that use 2 antibiotics, such as amoxicillin and clarithromycin, with a PPI is known as triple therapy. In areas where there is clarithromycin-resistant bacteria, multiple drug therapy, known as quadruple therapy, uses tetracycline and then an antibody antiproazodal drug such as metronidazole and a PPI and a bismuth. Bismuth compounds such as pepto-bismol stimulate mucosal bicarbonate and prostaglandin production to promote ulcer healing. In addition, bismuth suppresses H. pylori. There are very few side effects other than a harmless darkening of the stools. Either multiple drug therapy is administered for 10 to 14 days. Eradication of H. pylori varies by treatment regimen. The duration of therapy 7 versus 10 versus 14 days. Patient compliance, because if you don't take the medicine, it's not going to work. There's a need to take these drugs frequently so the patient may get off their schedule, especially when you're having to take something 3 or 4 times a day. And then drugs on different schedules for an extended period of time, such as antibiotics, can lead to antibiotic resistance. For a peptic ulcer that is in the duodenum, and here's your drug I was telling you about, sucralfate or carafate, old drug, been around a long time. It acts locally to form a thick compound that adheres to the ulcer, protecting it from stomach acid and bile acid so it can heal. And it actually kind of binds to that ulcer and puts a protective barrier around that ulcer. So it's an amazing drug. In patients who have NSAID-induced ulcers, the NSAID being used should be discontinued and another analgesic used, and it should be enteric coated. If that's not possible, then PPIs, H2 blockers, sucralfate, or prostaglandin analogs should be used to promote healing the ulcer. Sucralfate binds to proteins in the ulcer base, forming that protective barrier I was talking about against that acid and bile and pepsin. Sucralfate also stimulates the secretion of mucus, bicarbonate, and prostaglandin. Prostaglandins such as misoprostol promote ulcer healing by stimulating mucus and bicarbonate secretions and by inhibiting acid secretion. Misoprostol is used to prevent NSAID-induced ulcers. Diarrhea is a common side effect of that drug, and the use of this drug is contraindicated in pregnancy because it can cause birth anomalies, abortion, premature birth, or uterine rupture. So you want to be careful with this misoprostol because it is a prostaglandin type drug, and that can cause uterine contractions. Non-pharmacologic therapy. In addition to pharmacologic treatment, patients are encouraged to maintain good nutrition. And they really kind of recommend, staying away from spicy foods, sit up right after you eat so don't come back up, limit your intake of seasonings and things like that. And they kind of recommend a bland diet, and people don't want to adhere to it because bland diets don't taste good. So you want to consume balanced meals at regular intervals, so you may have to have like 6 small meals a day instead of 3 large meals. It is important to teach patients that bland or restrictive diets are no longer necessary, but and like I said, they may recommend a bland diet, but really it's more like recommending that you watch the spicy foods is more of what they're looking at. Mild alcohol intake is not harmful, mild, so that's very little. Smoking is discouraged because it slows the rate of healing and increases the frequency of relapses. And some of this stuff is still being researched as to what the best approach is. Complementary, so what do we look at? The main integrative health options include lowering the patient's stress by any health option they enjoy, such as yoga, walking, listening to music, or listening to Dr. Locklear record lectures, and so forth. Increasing fiber in the diet to prevent further ulcers and taking 25 to 50 milligrams of zinc each day to assist in healing, because we know zinc does help the healing process. Ginger may be used to assist with any nausea or vomiting. There is little evidence in relation to PUD, but small studies have shown that there are some benefits with the ginger. And some people just like ginger. Lifespan considerations, I am going to let you read this on your own. So children and pregnancy, and it's just 3 little paragraphs there, so I'm going to let you read that on your own. But it does happen, and one of the reasons it is happening in children is because of childhood obesity and the way they eat sometimes. Okay, and there's your pregnancy and then the older adults. So make sure you just read those 3 little paragraphs. Nursing process. Although it is difficult to predict which patients will develop PUD, nurses can promote health by advising patients to avoid risk factors such as excessive aspirin or NSAID use and cigarette smoking. And I don't know if you all are aware, but there's like Goody powders and BC powders, And if you're prone to PUD, you don't need to be taking those things. I'm really surprised they still make Goody powders and BC powders because of some of the adverse effects from it. Nurses should encourage patients to seek treatment for manifestation of GERD or chronic gastritis, both of which are associated with H. pylori infection. So what is our assessment? So when we observe and the patient interview, we assess for complaints of epigastric or left upper quadrant pain, heartburn or discomfort, its character, severity, timing, and relationship to eating. Measures used for relief: nausea or vomiting, presence of bright blood or coffee grounds appearing in the vomitus, current medications, including use of aspirin or other NSAIDs, and cigarette smoking and use of alcohol. And this is a picture here of what coffee ground vomitus looks like. And it looks just like coffee grounds, but it's old blood in the vomitus, and it stinks to the high heavens. When you see it and ever smell it, you will never forget it, trust me. And here's another. This is the emesis basin where someone threw up coffee ground emesis, and it looks just like coffee grounds from the coffee pot, but it's blood in the emesis. The physical exam: documented general appearance including height and weight relationship, vital signs including orthostatic measurements, abdominal examination including shape and contour of the abdomen, bowel sounds and tenderness to palpation, and presence of obvious or occult blood in the vomitus and stool. So we want to really give a thorough observation of these things. Diagnoses: potential for bleeding, risk for fluid volume deficit, weight loss, chronic pain, and sleep disturbances. And this is not all. It's not a conclusive list. What are our goals? The patient will demonstrate no complications related to bleeding, such as hypovolemia. The patient will demonstrate no signs or symptoms of infection. The patient will demonstrate fluid balance, including maintenance of urine output of at least 0.5 milliliters per kilogram per hour. The patient will demonstrate dietary intake that meets nutritional and caloric needs, because some people can't eat with PUD. It hurts their stomach, so they don't eat, and now they start losing even more weight, and they can get electrolyte imbalances because it just hurts them so bad to eat, and they're not eating properly. The patient will verbalize maintaining pain at a tolerable level. So let's look at our implementation. So what are we going to do as nurses? PUD is managed in home and community-based settings only as complications typically require treatment in an acute care setting. The priorities of nursing care for the hospitalized patient with PUD include restoring and maintaining fluid volume balance, reducing discomfort, maintaining nutritional status, and preventing or rapidly identifying and intervening for potential complications. Look at box 10.4 and you will see priorities for the patient with the complications, and this is on page 702, okay? Look at the, 762, I'm sorry. On page 761, you have patient teaching, and this is home care for patients with PUD. Prescribed medications, importance of continuing the therapy, don't stop the therapy, talk about NSAIDs and smoking, avoiding those aspirins, and so forth. So make sure you read all of that, okay? So we want to restore and maintain fluid balance. Erosion of a blood vessel with resultant hemorrhage is a significant risk for the patient with PUD. Acute bleeding can lead to hypovolemia and fluid volume deficit, which can be critical, which can lead to decrease in cardiac output and impaired tissue perfusion, causes all kinds of problems. The care of a patient with PUD who is at risk of PUD bleeding starts in the acute area and then moves to outpatient with the care in clinics and at home. So what do? Monitor stools and gastric drainage for overt and occult blood. Assess gastric drainage, vomitus or drainage from the nasogastric tube. Drainage is bright red with possible clots is acute hemorrhage, and dark red or the color of coffee grounds is when it's old blood been in the stomach a while. Hematochezia is present in acute hemorrhage. Melena, which is black tarry stools, is an indicator of less acute bleeding, because it's been in there for a while. When small vessels are disrupted, bleeding may slow and not overtly be evident. With chronic or slow GI bleeding, the risk of fluid volume deficit is minimal, but anemia and activity intolerance will be very noticeable, because as we're losing blood, we're not going to have the oxygen in the hemoglobin to give us what we need. Maintain IV therapy with fluid volume and electrolytes. We want to prevent shock, whole blood and packed red blood cells. Insert a nasogastric tube. You want to record the output every hour and then maybe every 4 to 8 hours. It removes blood from the GI tract, it prevents vomiting, and it gives the stomach a chance to rest. It's what we call decompressing the stomach, because you're getting that blood and old vomitus and stuff out of the stomach. Monitor the hemoglobin and hematocrit, electrolytes, BUN and creatinine, because as we become hypovolemic, our kidneys are not going to function, and as our perfusion changes due to the blood loss, we're going to see changes in kidney function as well. In acute hemorrhage, initial results may be within the normal range because both cells and plasma are lost. Loss of fluids and electrolytes with gastric damage and diarrhea alters normal levels. Digestion and absorption of blood in the GI tract may result in elevated BUN and creatinine levels. Assess the abdomen, bowel sounds, distension, abdominal girth, so you're measured all the way around the stomach, how big it is. Is it tender? You want to assess every 4 hours. Record your findings. Borborygmy, I can't say that word, or hyperactive bowel sounds, and I did not say it correctly, but there's another way to say it. But it's hyperactive bowel sounds with abdominal tenderness are common with acute GI bleeding. Distension, increasing abdominal girth, absent bowel sounds, or extreme tenderness with a rigid board-like abdomen are indications of perforation. And then bed rest, head of bed elevated to promote breathing, loss of blood volume. Also, you need to elevate the head of the bed to keep from regurgitating back up in the throat, and they may aspirate those stomach contents as well. You may see dizziness or syncope, which is fainting, when they're standing up due to the orthostatic blood pressures and the blood loss. Managing pain. The pain is often predictable and preventable. Pain is typically experienced 2 to 4 hours after eating, as high levels of gastric acid and pepsin irritate the exposed mucosa. So you ever think about this? You ever had a little, I don't know, little abrasion or something, and you got some hand sanitizer on it with alcohol, how that burned? Well, that's what this is talking about here. Assess the pain, administer these medications that are listed here for you on 762, your antacids, your H2 receptors, and teach relaxation techniques. Avoid making assumptions about pain. Acute pain may indicate a complication such as perforation, often manifesting as severe epigastric pain. It's sudden and rigid board-like abdomen, or it may be totally unrelated because it could be angina, gallbladder disease, or pancreatitis. So we need to be very careful. Facilitate adequate bed rest. And so you usually see nighttime ulcer pain, which is between 1 and 3 a.m. Because they're fasting. And remember when it said if your stomach's empty, then you're going to have that pain. Take your medications, your PPIs, your H2 receptor blockers. Instruct the patient to limit food intake after the evening meal, eliminating any bedtime snack, eating before bedtime. You need to stay upright after you eat, and you don't need to eat right before you lay down. Promoting balanced nutrition. In attempt to avoid discomfort, The patient with PUD may gradually reduce food intake, sometimes jeopardizing their nutritional status, and I said that a while ago. Anorexia and early satiety, satiety means that you're satisfied when you've only eaten a few bites of food, are additional problems associated with PUD. Assess the patient's current diet, including pattern of food intake, their eating schedules. You want to make sure they're eating enough. Refer them to the dietitian. Monitor for complaints of anorexia, fullness, nausea, vomiting. Monitor lab values for indications of anemia, so your hemoglobin and hematocrit would be good indicators. And you want to monitor for therapeutic and side effects of treatment measures such as oral iron replacement. And iron can make you sick on your stomach if you don't take it with food. So here, this could be something aggravating your stomach, so you got to teach how to take it. Instruct the patient taking oral iron replacement to avoid using an antacid within 1 to 2 hours of taking it. Antacids bind with oral iron and blocks their absorption, so you've wasted your time. Anemia can result from poor nutrition or absorption or chronic blood loss in the patients. Oral iron supplements may cause GI distress, nausea, and vomiting. If these side effects are intolerable, notify the healthcare provider. Safety alert. Advise the patient to report increasing or persistent symptoms of anorexia, nausea and vomiting, or fullness to the healthcare provider. And that's definitely needs to be done. And then your evaluation, of course, did it work? Is it controlled? Is the bleeding stopped? Are they on a balanced oral intake and output? Is there a reduction of the pain, and are they able to sleep and rest at night? If the patient does not progress satisfactorily to the expected outcomes, the nurse must complete a thorough assessment, particularly the patient's reported pain level, diet tolerance, and vital signs. Signs and symptoms of further bleeding, such as abdominal pain and increased pain, will require notifying the healthcare provider, and that abdomen will become more rigid and board-like, and you'll continue to have hypoactive bowel sounds. Diagnostic workup may include a CBC to look for lowering of the hemoglobin and hematocrit. IV fluids may be reinstated, as well as IV pain medications such as IV Protonics, NPO status to calm down the gut, a nasogastric tube to decompress the gut, and IV proton pump inhibitors. And so you, again, you may have to go back, if there's no relief. Surgical or endoscopic consult may be conducted because they may need to go down and look and see how much damage is done to the mucosa. And hopefully I'll have a case study. There's a case study on page 763. I would read over this. As I've said before, I do like to get test questions from the nursing care plan. Gives you a great case study and gives you some great nursing interventions to follow through with this patient. Thank you.